No, thank you. Right. All field. Right. Yeah. Oh, my. Yeah, oh, yeah. Just assuming somebody has spoken. Out here. I'm thinking about the thing. Yeah, so we haven't changed. Thank you.
log in the team. Let me know if you can hear me on your speaker. Although we're gonna mute yours, but you can hear me on your laptop? Perfect. Perfect.
Welcome to the
You want?
It doesn't matter to me.
You calling?
Go ahead.
Good afternoon, everyone. We'll take our seats and we're going to get started. We've hit the witching hour, as it were. No, he's going to stay out there. Well, thank y'all for being here. We're going to kick things off with our commissioner. So Commissioner Carlson, you want to come up and give some welcoming remarks?
All right. There's an echo. The only thing worse than listen to me is listen to me twice. Test. All right, there we go. Well, thank you all for being here, and thank you for all put this together. I hope my team, my partners here can attest to the fact that whenever we do these things, I like to start off with saying thank you to everyone who assembled the group, had the vision to do this, because events like this don't magically happen, from the slides to the room. Cedric, thank you. From Lipton and Joe, all the preparation you made. So thank you for everyone, both in attendance and joining us virtually. I'd like to also thank our partners from Sellers Dorsey and Deloitte and GHA. Carrie, thank you for helping us talk through all these matters. It's not lost on me that not only are many of you stakeholders in this program, but many of you are actually the visionaries and the architects that put these programs together in the first place. That isn't lost on me, that a lot of what we're discussing today are, it's due to your creativity and vision to actually put these things together to strengthen our entire provider network. But as we know, when things have to be evaluated and assessed annually, that means we need to hopefully foster a spirit of over communication and transparency to kind of together talk about the best path forward on any given year. It's definitely a game of chess, not checkers, as we think through not only decisions needed for this planning year, but in a program as dynamic as this, how each piece impacts the next piece for years ahead. And that isn't lost on us, how all of these things play off one another. And so I think that, Kaylee, you're going to sing the national anthem after me. So go ahead and get ready. But that spirit of communication has brought us here today. So there are a lot of important decisions ahead of us. So many of you know that if I'm good at one thing, it's that knowing my lane and knowing when I need to quietly step aside and let the grown-ups take the wheel. So that being said, thank you again for being here. Thank you for the active participation. And at this point, I'll hand over to Joe Hood, our Chief Operating Officer here at DCH. Thank you, Joe.
Thank you, Commissioner. Thank you all for being here and for those online for joining us. What we wanted to do today was to give an opportunity to explain where we are with the HDPP programs. We've realized that we have, such a large number of participants, and we've had discussions with the association. We came to an understanding that it might be good to have a meeting like this and just to have a transparent discussion and overview of where we are, where we think we're going for the upcoming state fiscal year, and to really explain how we use our partners to come together and drive this process and expect to do so year over year. And then certainly we hope to address any questions and answers that you guys may have. But it was readily apparent as we've done this with at least one hospital that some of what brings all this together is not readily apparent to everyone. So what we've done today is we prepared the agenda and we've asked our contractors, our partners from our actuary partner at Deloitte and from Sellers Dorsey, our other contractor that helps us with the hospital side, to come forward and provide their respective roles of what their status and role is for this year and for upcoming, and to give a status update of where we are with the various years and reconciliations. And what we're going to do is start out with the actuarial side with Deloitte, where I have JD come forward and run us through that. And then he's going to turn that over to Sellers Dorsey to Kevin, which is over on this side. And then Kevin's going to run us through the rest of those slides. And then we'll have questions and answers at the end. And then anywhere throughout, we talked about this beforehand, if y'all have a question throughout, if you can prompt us, we'll be happy to stop, answer that question then and address that. Brian Lipton is here with me. He's running our slide deck and he'll be on the side. So we'll look for cues from him. But without further ado, I'm going to turn it over to JD and get us kicked off. Thank y'all so much.
Thank you, Joe. Good afternoon, everybody. Do my best to continue to speak into the microphone. Thank you for the introduction. As Joe mentioned, I'm just going to kick us off with an overview of the directed payments, take us through a status update for state fiscal year 23, 24, and 25 directed payment programs, and then I'll turn it over to my friend over here, Kevin, with the Sellers Dorsey team. So as far as the directed payment overview is concerned, CMS authorized states to use state-directed payments to direct funds through Medicaid, through managed care payments to accomplish specific goals and system reforms. Because Medicaid is a joint venture between the state and federal government, there's no incremental state general revenue contribution required to fund the directed payment program. It's all funded by the eligible providers. For the actual payments that occur to the providers, CMS does require that it has to be tied to Medicaid utilization and achieve at least one of the state's quality strategy goals. The payment that's required, the payment requires an evaluation plan that includes quality measures, baseline statistics, performance targets to measure how the program is improving access and quality to the managed care population. So within that CMS parameter, the states do have the flexibility to design the payment program, but ultimately that design has to be approved on an annual basis by CMS. To date, DCH has 5 DPPs that work in concert with each other and with DISH to significantly benefit several Georgia providers. All right, so moving on to the role of the state's actuary. So as the state's actuary, we do certify the rates for the state's managed care program for the Georgia Families Program, Georgia Families 360, as well as Planning for Healthy Babies. And as part of that certification process, CMS does require us to document specific elements around the state-directed programs. For the directed payment program specifically, we do collect and analyze the data to support production of materials related to payment of those directed payments. Referencing that CMS requirement for us to document certain elements related to DPP and the rate certification, CMS publishes a rate development guide that prescribes what information they want every year that we certify rates so that they understand what is included in the state-directed programs. So that ensures compliance with regulations, it ensures consistency in materials submitted, and transparency for the federal review. So as far as, hop back real quick. As far as contract arrangements, those any kind of contract arrangements that direct Medicaid expenditures, those have to be included in the rate certification and must be developed in accordance with all kinds of federal regulations, such as those cited on the slide here, and follow the generally accepted actuarial principles and practices. So all state-directed payment programs do have to be referenced in the rate certification. All right, so digging in just a little bit more, in terms of what CMS prescribes for the documentation and the rate certifications, as I just mentioned, the initial rate certification does have to include control names for each one of the state's directed payments. It has to include estimates for how much those payments will amount to be, a statement that we certify the payment term, confirmation that the rates consist of analysis consistent with the preprint, and how each state-directed payment program or arrangement is reflected in the payments to the managed care plans. That along with estimates at a per member per month basis for every rate cell that we certify. Following the initial rate certification, we do also have to submit documentation to CMS to make sure that we document what the final payment level is that reflects actual utilization for the period, as well as submit additional documentation if distribution methods or the total payment level changes from what was originally submitted. Any questions so far? All right, so no questions. Next up, I wanted to just share a little bit of a higher level overview of how directed payment programs actually function from start to finish. Some of you may be aware of the state's efforts to submit preprints in time for CMS approval for each contract period. So every directed payment starts with a preprint. That's where we define the reimbursement methodology, the stake or the participant criteria, as well as goals and funding mechanisms. At a high level, some of the activities associated with the preprint are collecting the pricing data, modeling estimated payment levels, and then ultimately that information leads to the submission to CMS of that preprint. That is also what we include in our rate certification document. Beyond CMS approval of the preprint, that's where something that you may be familiar with, referred to as interim payments, occur, where we use some sort of proxy utilization data to get some money out the door before the period is ultimately reconciled. So that is based on proxy utilization data. There's modeling that goes along with that. And then ultimately, once the period has ended and we can look back and see what actual utilization was for the period, we can conduct final reconciliation analysis to true up the payments to what actually occurred during that period. And then, as I mentioned on a previous slide, we do have that follow-up documentation that has to be sent to CMS to document what the final payment level was. All right. So as far as status updates for each fiscal year in process at this point, for fiscal year 23, interim payments have occurred and a final reconciliation analysis is in process to true up the payments to actual utilization for state fiscal year 23. At this time, payment timeline has not yet been determined, and we've been working through analyzing the data underlying that ultimate payment. Providers in that actually had an initial recoupment status for fiscal year 23 did not receive an interim payment for fiscal year 23, nor a interim payment for fiscal year 24. For fiscal year 24, outside of just documenting where we are or sharing where we are in terms of payment status, there was also a change on account of one provider's ownership type changing, which resulted in us needing to submit a preprint amendment to CMS. That was submitted back in February of 2024, and there's no change to date or to the effective date of that preprint. So as far as SFY 24 payments are concerned, those were pushed out to several participants at a 50% payment rate using the fiscal year 23 CMO utilization data. And then as far as payments to private hospitals, those are in process and they should have occurred no later than March 22nd. And then as far as the state fiscal year 25 preprints, we're still in the preparation phase where we're gathering the necessary elements to prepare all the documentation and submit that to CMS by May. Yes.
Oh. So I'll repeat my question for the audience that's on Zoom. For the 23 recon, how much claims run out are you picking up by doing the reconciliation now, for example? Are you doing 6 months, 9 months?
Yes, we're planning on using state fiscal year 23 with paid through December of 2023. So 6 months have run out on that data.
Okay, thank you.
Got a question back there.
With the backlog in processing disability applications, it's taking 9 months to have those processed. So a 6-month run out doesn't seem that it would capture all of the what we call Medicaid pending days that would be in claims that could be captured with a 6-month run out. How have you factored that into determining a 6-month run out?
So typically the state actuary determines like what amount of run out is justifiable based on typical claims lags. And in my experience, I'm not speaking for the state in particular, but in my experience, the statistical like growth of the tails beyond 6 months is not significant. But we can certainly take that back and talk with the state about that. Any more questions?
Yes, I have a question from Zoom.
Yes, go ahead.
I believe last year, the 75% interim payments were paid out, and then another 25% interim payment was paid out within the state fiscal year. Is that expected again this year where essentially 100% of the interim payment will be paid out during the state fiscal year, or will the remaining 50% interim payment be paid out next state fiscal year?
Joe will take that.
So likely we're going to go to a more historical approach of 50-50 on that. Last year, you may recall, the PHE was ending and there was a significant FMAP advantage to trying to get as much payment out as we could because the FMAP was attributable to the timing of the interim payment. So that's why we really made every opportunity we could to get as much payment as we could on every program. And that's why we went to 75% within that quarter. But now with reconciliation that's happening and all the things that we have ongoing as explained in the status update, we'll probably go back to more of a 50-50 approach. I don't know that timing is going to allow for that. We certainly will strive for that, but I don't believe, given how that's going for everything to work out and with run out in the analysis, I'm not certain that we will hit before June 30th.
All right, if there's no more questions, I'm going to turn it over to Kevin.
Thanks, JD.
Thank you.
Thanks, JD. I'll do one slide and then I'll pass it right back to you for the next one. So good afternoon, everyone. I'm just going to give a brief overview of the public and private hospital DPP. So at a high level, the public hospital directed payment program is larger than the private HDPP program. There are more hospitals, and so the estimated impact for state fiscal year 24 for the publics is $295 million. For state fiscal year 24 for the privates, it is $175 million. The two bullets there below in terms of eligibility are exactly as approved by CMS. So it is straight from the approved preprints. So it includes for the public, state government and non-state governmental hospitals, and it does exclude critical access hospitals. In terms of the private hospitals, the case is private acute hospitals, and it excludes your general cancer hospitals, your freestanding children's, your rehab, psych, and LTAC, and as well as your critical access hospitals. In terms of the methodology, which we'll go into more detail on the payment side with JD walking through those steps, the application of the payment add-ons for 24 to determine what the Medicare equivalent was on top of your Medicaid CMO base payments is a 47% increase on your inpatient-based reimbursement, and then an 18 or almost 19% add-on on your outpatient reimbursement. And so those are updated annually. So for fiscal year 25, you all can expect that those percentages to be different. And then lastly, just to reiterate, non-federal share for these programs for the public hospitals is via an intergovernmental transfer, IGT, and for the privates, it is via the provider assessment. And I'll pass it to you, JD, and then we'll go through the rest.
Thank you. Got those a little out of order, but all right. So just to talk a little bit more about the details of the hospital DPP payments. We covered the overview a little bit earlier. Just wanted to share a little bit more information, give you a little more insight on how the payment amounts are determined. So we start with collecting the Medicaid managed care data from the providers and the CMOs. We collect from both sides so that we can validate, do some benchmarking, make sure that we're both seeing close enough numbers that we know we're confident we have the right payments. Following that, we do calculate the uniform percentage increase based on the state's inpatient outpatient analysis, where Medicare is used as the equivalent. And then we account for Medicaid managed care CMO mix by weighting the payments on managed care experience by facilities. That uniform percentage that results from that analysis is what is applied to the claims to determine the payment level. Now, as I mentioned earlier, there is typically an interim payment. That amount is based on historical CMO utilization. The final reconciliation payments are based on actual experience for the period. And the final payment does account for the fact that interim payments were paid out previously, and that we calculate a final amount, we reduce that final amount by what has been paid, and then the remaining amount is your final reconciliation payment. As Kevin mentioned, in state fiscal year 24, the uniform percentages for inpatient were 47.46%, outpatient was 18.76%, to bring Medicaid managed care, inpatient, outpatient up to 100% of Medicare. For state fiscal year 25, we will be updating the analysis to reevaluate what those uniform percentage increases are, and that's what you can expect to see for state fiscal year 25. Any questions on that? No? All right. Back to you, Kevin.
All right, so that does cover the payment side of things. So we'll talk through first the step-by-step process for how the assessment is calculated, and this is specific to the private HTBP and strong payments. So this assessment does not interact with the other assessment programs in Georgia, Tier 1 or Tier 2, as they're commonly referred to. So really the step number one is there is a process of data collection of the inpatient net patient services revenue for each eligible private hospital that comes from the state's hospital financial survey, which is completed by the providers on an annual basis. So that is a source for where we collect the inpatient NPSR. After having that, we have to determine what the non-federal share is needed for your Georgia Strong and your private HTBP total payments. And that's Georgia Strong, just the private hospitals. And all eligible providers are required to pay a single uniform assessment per the CMS regulations. So thirdly, after knowing what your non-federal share is, you calculate your uniform assessment as a percentage, and that is determined by taking the ratio of the total non-federal share as a numerator to your total inpatient NPSR for all the eligible private hospitals. And so for context, for state fiscal year 2024, HFS data from 2021 was utilized as the basis for your inpatient NPSR. And so one of the things that the state does take into consideration on an annual basis and how this impacts net contributors is which year provides the most optimal results for the provider community. And so that's just some more of the background of what was completed for your state fiscal year 2024 payments. I'll pause here and see if there's any questions on those steps. Carrie has. Go right ahead.
You might as well just sit over here. So in terms of using the 2021 hospital financial survey, do you have a sense of what CMS's expectations are going to be going forward in updating that? How much discretion do you think the department is really going to have over time to, like, for example, stay at the 21, which would clearly make it probably more advantageous than updating it to something more current?
Yeah, that's a great question, Carrie. The state really does have broad flexibility on which year to use because the approved waiver for this assessment program is vague. So it provides that flexibility, and it really depends on state. It varies from states to states. Some states update their basis every year. Others update it every 3. But here the state has very broad flexibility on doing that. So the update to 2021 really was driven by a benefit to the providers community in general. So that does not mean that in the future year, we'll be using 22 HFS data. So that analysis is really completed way before the preprints go in, so that the state has the information they need to make that decision. So, but to answer your question directly, CMS really won't really interfere with that. The state because of how vague it is in terms of the date year that's utilized for the HFS, they have that broad flexibility,
Great, thank you so much.
of course. Right. All right, so this is really just to list out the exclusions. Very similar to the payment side. So hospitals that don't pay an assessment are not eligible to receive a payment. So here's the list of hospitals. There is one grouping that is italicized, given that rural emergency hospitals is more emerging eligibility criteria that the state is looking at closely. They are not explicitly excluded in the approved preprint, but there has been some dialogue and clarity received on whether or not they are eligible on a go-forward basis. And the current consensus is that rural emergency hospitals would be excluded from the payments assessment and the payment side. So really just wanted to call that out, and then we'll go into the assessment rate driver. So when there's questions on, how is your assessment determined, these drivers are really going to be what your assessment amount is going to be. So really the main one, if you look at it from a state fiscal year 23 perspective to a state fiscal year 24, the FMAP was a big driver for all providers. Like Joe mentioned, because of the public health emergency, the state was able to take advantage of a 6.2% add-on to the FMAP. So that benefited the provider community overall in state fiscal year 23. For state fiscal year 24, the assessment calculation is taking into account the standard FMAP in Georgia, which is 65.89%. The other big driver that fluctuates assessment amounts is the number of private providers. And this second driver really comes into play with the last driver that's listed in this table, program dollar size. So with the introduction of new providers, either adjustments to eligibility in the HCBPs or Georgia Strong, specifically private hospitals, that will essentially create a situation where hospitals that are already participating have to pick up additional state share for new hospitals to participate. And so that's what happened from state fiscal year 23 to 24. There was an introduction of 2 new providers that also influenced your assessment amount. Number 3 is Medicaid CMO utilization. Just like JD explained, there is an annual more state share. I can pause, just, yeah, no worries. Okay, but they can still hear us, is that right? Okay. All right, any questions from folks in the room? Alan?
Had to allocate that increase between how would that break down?
Have to look at it more precisely. Zach, I know Zach, our assessment and dish experts on the line, if he has a precise number, I would say both. Those are the main contributors more than any adjustments that happen on an annual basis for Medicaid, CMO, and inpatient NPR. I don't want to put out any guesses, so let me take that back and look into that and get back to you, Alan, if that works. I have a suspicion, but I want to base it on the facts. Oh. Redo. Where did I get muted? So I can just go back there. This one? Okay. Driver, apologize for the folks in the room. I'll do this one more time. So for the folks online, what I was saying is when you check out your assessment amounts from an annual basis, this list here is really the main drivers that will influence what your assessment amount will be. So starting with FMAP, because of the benefit that Joe mentioned last year to take advantage of the public health emergency FMAP of 6.2% add-on, there was a benefit to the hospital community last year versus now in state fiscal year 24. The standard FMAP in Georgia is being utilized to 65.89%. The second main driver that is tied to also the program dollar increase is when new providers, private providers specifically, are newly eligible for the program. That will fluctuate your assessment because there are new providers with new directed payments, and essentially the rest of the eligible private hospitals that are assessed need to support the state share of those new providers eligible, whether for strong or for private HCPP. The third main driver is your Medicaid CMO utilization, which JD walked through is an analysis that's completed on an annual basis. And of course, no year is the same in terms of Medicaid CMO utilization, so that also plays a part here. And similarly for your inpatient net patient services revenue, with the update, there were some, the general comment I made earlier was that on a general basis, hospitals' inpatient net patient services revenue did increase, as well as the uniform percent increase occurred as well. So there's just more inpatient net patient services revenue to assess, which has caused an increase in assessment in the state share. And the last note I'll just mention is in state fiscal year 23, the uniform percent increase was estimated to be 2.58%. And in state fiscal year 24, based on the 50% interim payment, it was 1.39%. So if you annualize that, that is a 2.78% that's uniformly assessed across all eligible private hospitals. So there is a little uptick there as well that changed because of all of these drivers that I just went through.
Kevin, before we go to the next slide, I did want, there was a question in the audience, and I don't know that y'all got that, but the question was, how significant is the drivers of the two new hospitals that came in with the cost report? And we can get a follow-up and get an exact number for that question. We don't have that readily available. But what I do want to reference is it is significant. I want everyone to understand that it is a very significant thing to look at new hospitals coming on. And to Carrie's question earlier, I'm not sure that maybe everyone is fully aware, but the cost report that we're referencing here, 21, drives who is eligible. So particularly in the teaching hospitals, because it's based upon the number of GMEs. So on the private side, what we have to look at from the state level is what is that going to do to the state overall for net revenue? Does it bring overall net revenue in? But also, what does it do to individual hospitals? We don't want to try and create contributors to this process. And we're about to talk about quality. And one of the things that we really need to understand and remember is that while we want to bring revenue to the state overall, to all the hospitals, and that is a significant goal for CMS, their goal is that we achieve these quality factors. And one of the things that we really need to do to allow the ability of each individual hospital to achieve quality is to have stability in revenue. So our goal is to try and keep it as stable as possible. If we can increase revenue overall to the state without driving others out, that's what we're looking for, with the idea that we need to maintain some stability so that we can work toward these quality goals that we're going to talk about next.
Thanks for the segue, Joe. Yes, so going to the quality measures for this program, and let me just level set in terms of this slide. So like Joe was mentioning, CMS really does look at these programs as what is the impact you're having on your Medicaid patients, specifically your Medicaid CMO patients, since this is a directed payment program. And so every directed payment program that is approved by CMS has an evaluation plan that is tied to the financial aspect. And so for the public and private HTPP program, there are two measures that are currently included in the evaluation plan. And what CMS expects and requires is that the state report data for a baseline period and set performance targets so that they're able to track these measures over time. And at a high level, it's also supposed to advance the state's quality strategy goal. So the state goal that's attached to these two quality measures, total inpatient average length of stay and plan all-cause readmission, is to increase appropriate utilization of levels of care. So what you can see from the table down below is that for state fiscal year 23, we don't have the results yet. We are working through that with the CMOs. So for these two programs, the CMOs are the data source, and DCH completes that on an annual basis. But what was required to be submitted to CMS were some baseline level information that the CMOs provided on the provider's behalf. Now, the process is really being created as we go and ensuring that it aligns with CMS's expectations. So the CMOs have taken really a large role in providing this level of detail for the state. And of course, having that information ready for the preprint submissions. So, because the CMOs are reporting this on behalf of the providers, the one step that's missing is provider engagement. And really, as a future next step, it would be, a great experience to have the providers review the data that's being submitted on your behalf and ensuring that it is aligning with the data being submitted. So again, building that feedback loop is going to be extremely important. And although this is not the basis of today's discussion, you all can expect some more information or potential meetings to kind of walk through this. Because one of the aspects is providing this at an aggregate level to CMS. But it would be an interesting analysis to see how providers are doing at an individual basis as well, and making sure that you all have a place to weigh in on those results. Right. So that closes out the HTPP portion, payment side, assessment, and quality measures. The one other part to this presentation is talking through the DISH component. So as you all may know, the DISH component is attached. Really, the state views it as one large program, and working in concert with the other DPPs. So in fiscal year 2022, the Georgia DISH allocation was about $493 million, and it was under an old allocation methodology that was in place for several years. And the first two bubbles under the 22 for small rural pool and urban non-small rural pool resulted in $76 million for the small rural pool and $416 million for the urban and non-small rural pool. So over $100 million was going to Grady. As a result of the new directed payment programs, not only Georgia Aid, but Strong and the hospital directed payment programs, there's been the opportunity for the state to essentially redesign and allocate those DISH dollars to other providers in the state of Georgia. And so the numbers under fiscal year 23 demonstrate a new DISH allocation methodology that essentially first fills the small rural pools. So instead of receiving $76 million, they've received an additional almost $90 million. and the remainder of the pool received $370 million. So just a couple of stats as well to add here is that with the reallocation of DISH dollars, with the development and implementation of the new DPPs, as a result, there were 12 hospitals that were essentially no longer eligible for DISH because they reached their hospital-specific limit. And so as a result of that, not only did the small rural hospitals receive $90 million, but there was also over $100 million that was reallocated to the remaining hospitals in DISH Pool 2. So really, when the state is taking an evaluation of this program, they're not looking at it from a DPP to DPP basis. They're looking at it from a total DPP and DISH basis as a system. So, and then of course, the outcome from the outset has always been to reduce Medicaid UCC in Georgia. And so those are some of the statistics on the slide here as well. Joe, Brian, anything you'd like to add there?
Yes. So Zach's on the line from Sellers, and when we had briefed on this previously, we have been looking at payment methodologies that we might change in the future to give those that I would say are at the margin or closer to the margin for net contributors and how that might impact them. And one of the things that we looked at is, well, if you increased the HDPP percentage, if you added that percentage and increased the payment there, would that be a benefit? And it was pointed out, with that, the HDPP, you have to do a private assessment and the private hospitals have to make that match. Whereas in DISH, that's a state appropriation or it's an IGT. So the point was made that if you increase HDPP, it impacts the DISH availability to that hospital on the HSL, and it means you get less DISH. And that's not a good thing if you're not providing the match for that amount. So I just want everyone to understand that we're looking at it carefully and looking at how we can best maximize payments that are going to go out to everyone. But I do want to emphasize again, as Kevin was saying, it is really holistic and they are very much intertwined because of how the money flows and how removing people with HSL, individual hospitals, creates this cash flow as you go down. So even those who don't hit the HSL, as y'all are aware, you're eligible for less, right? So almost all the teaching hospitals, their money is moving out of DISH that's being replaced by the DPP. And the same is true if we were to increase the HDPP, it would move each individual hospital up on the HSL. So I think that's an important point to note, and just want to be transparent about that so y'all understand what we're looking at and what we're trying to accomplish when we look at the different payment methodologies. And then I think we can go to the next slide and it's a Q&A, Kevin.
Yeah, just brief Q&A that points out what is the eligibility criteria for DISH Pool 1 and DISH Pool 2. So really, your DISH Pool 1 are hospitals, rural hospitals that have less than 100 beds and are in a county having a population of less than 50,000 people, as well as state-owned and operated acute care hospitals. In terms of DISH Pool 2, it's just all the rest in simplistic terms. All right. Yeah, good here. All right. So back to Joe's point, there are some dependencies that are important to consider when the state makes DISH payments out to providers. And so firstly, on the federal side, the state pays very close attention to any policy adjustments that are happening or conversations that are happening on a federal basis, as there have been some conversations and discussions about potentially reducing the DISH allotment for states. And so with the recent spending bill being passed on March 8th, they really kicked the can down the road. So the state does not have to solve for that in state fiscal year 24. But prior to making any DISH payments, the state is really waiting for the go-ahead in terms of are there any changes going to happen? And so that's the first point on the federal side. The second point is on the state side. The other dependency is whether the state budget has been approved. That includes the appropriations amounts for the private hospitals receiving DSH. So ensuring that they have the authority to make those payments on behalf of the private hospitals. And that budget was approved on February 29th.
The only point I want to emphasize is, and I think everyone knows this, is the federal budget is really critical on this. You know, they keep kicking the can, as Kevin referenced. So even though they pushed it out to January, to the end of December, you know, we've got to wait for them to pass another federal budget next year. So we'll be in the same posture as we move forward, and unless they finally remove that requirement, which doesn't look to be probable. It looks like they're going to do it year by year and extend out into a next appropriations year. So I just think that's critical for everyone to understand, because if they delay the federal budget and that provision, as they did again this year, all the way to March, you know, we're well into the federal fiscal year and they haven't indicated. In fact, they actually sent us notice that we should expect cuts for this early on because they didn't know if it was going to be extended or not. So we do get mixed messaging, and it's just one aspect of that we really have to wait on. The state appropriation, we're more sure of on that. I mean, we have that in there, and we do need to make sure that that budget passes, but it's really the federal portion that's really driving this, that we need that assurance, and we think they're going to do that. I think all of y'all know that. They've done that every year since ACA passed, and we expect that to continue, but we just have to wait on that final decision before we can move forward, and that's really impacts our payment process. I know y'all like to know, well, when are those payments going to come out, and how is the flow going to happen? And it's always driven, for the most part, either by a CMS approval or by federal or state budget approval.
Okay, so this is as we start to think about future program years and really what's on the docket at the CMS level. CMS did release a proposed Medicaid managed care rule, which is, we've all been following very closely. And one of the suggestions or proposals that is discussed in the rule is a potential cap on STPs. What they've included in the proposed rule is language that essentially suggests a 10 to 25% cap on of total managed care spending for STPs. And although we don't know what the decision will be, there is some rumors that it could be implemented. However, it's still too early to tell until that rule comes out, and potentially later this spring in April or May. We also don't know how CMS expects states to calculate the cap. So there is still some uncertainty there. Based on our knowledge and how we think that CMS will calculate or want it to be calculated, Georgia is around the 24% threshold. So if CMS decides to implement a 25% cap, Georgia is bumping right up into that ceiling. If they decide to put it at 10% or 15%, that puts some key decisions in the state's hands to determine what are the next best steps to evaluate and potentially redesign and redesign the programs. So that's just generally the remarks that are coming out of the proposed rule, and just wanted to put that on the radar, as that is, Joe, what you all think about when implementing new adjustments.
Thanks, Kevin. The only other point I want to make is our expectation that we believe that we'll be submitting preprints prior to this draft rule coming out. So our expectation is that this next year is going to be under the current same atmosphere as we have, and that any new rule would probably take effect post that time frame. Now, that's not a given. They could, CMS could say that they're going to take effect at a date certain that would impact us before July 1, but that's our thought process, that we would probably submit in this April-May timeframe. And the best knowledge that we have is we probably will not see this proposed rule until the end of May. which would be after we've made that submission. So that's the thought, is we would have made the submission. And since we don't plan on methodology changes, we think we would have a quicker turnaround this time, and that we would be moving forward with the present day strategy of what we have. And that's the other point I wanted to emphasize. That's one of the reasons this managed care rule, that the state has definitively said we want to stay where we are to the extent that we can as far as methodology, because we don't know what the impacts are going to be from the managed care rule. We don't know what it is going to be with the details, and then we don't know what the challenges to that might be, or what the outcome is going to be. There is some discussion that even if they do put in a cap, that doesn't have legal standing through an administrative rule process, and that it would be immediately challenged because there would be states similar to us that would be immediately harmed by that, and how long would that take to resolve? So that's our current status. Is we're hopeful that we would have one more year, think we will, at our current state, and then at the end of May, we hope to it may occur before then, but that's what I'm hearing is likely it would be right at the end of May. And for those of you who may not know, that has to do with the congressional deadline. If the executive branch doesn't do it by a date certain, then it allows Congress, to my understanding, to have some insight into that rulemaking authority. So they want to do that prior to the deadline, which is right at the end. And of course, the budget process is also involved in that. And since that has passed, perhaps we'll move on and we'll hit that May deadline on this is the thought. Yes, sir. Okay.
Can DCH alter / update the cost report eligibility for Georgia? Fairly easily, given that HFS can also be. I think that all ties.
Well, the cost report can be updated upon submission, but it goes back to what I was speaking to on the previous slide, is that can have tremendous impacts on who's eligible and who is not. And then if we add additional hospitals, for example, then that most likely would mean that we're going to drive margins on some who are close to net contributing. So we have to look at that as a whole in that aspect. We can do it, but it is problematic in the event that it creates contributors. We have to look at it on a whole and say, well, is that going to benefit the state on a whole? And what does that do again to every other hospital's ability to manage the quality goals that we're trying to achieve to keep this program overall? That's a great question. So as we stand today, we only drive when you take into account DISH, that there's no net contributors. When you look at everything holistically, including DISH, that there's not a net contributor. And we're working very hard to keep that in place. And that's what we want to do. Now, there are those who are driving toward margins. Some of them are here today, and I've had discussions with them where, particularly if you look at one supplemental program by itself, they may be net contributing. So it's in my view, it's right on the line of where we are, and that goes to the cost report again. Okay.
Is the inpatient ALOS adjusted for CMI?
Inpatient adjusted for
ALOS.
Yeah.
Adjusted for CMI.
We'll have to check the measure definitions on that one. Okay. But it is limited.
Okay.
We'll check that one.
We'll have to follow up and get back on that particular question.
Still have to check.
Okay, great.
We completed the correct. That's where NQ.
Oh, and Q&A, right.
Apologies.
So are there any other questions that those online would like to present or in the audience? Okay.
DMO encounter data. That's DCH. What is reported? Payments as active. That's JD.
I think you talked about that earlier as we.
Yeah. Thank you for the question. Yeah. So I'm not entirely sure what particular issue you're referring to there, or how the encounter data is considered unreliable, but the data as reported from the CMOs is what is used for DPP payment. When it comes to final reconciliation analysis, we do request the same payment data from all of the providers to compare to that CMO data, and that's how we determine that it's viable.
Joe, Russell, Commissioner, thank you for hosting this conversation. Thank you for hosting the meeting. Obviously, and all the hats I've worn, this effort has been a tremendous partnership by so many people in this room and elsewhere to design, develop, and implement these, and now to maintain them. And Joe, to use your words, in the most in the manner that provides the most stability as possible. I think I know the answer to this question, but I just want to ask it publicly. So, and really to give either one of you the forum to address it. If we see the caps come into place, I agree with your assessment, Joe, that makes sense that if we have to have rate certifications and other program materials in 60 days prior to the beginning of the, rating period, it would seem unlikely that they would impose new rules within 30 days and expect us to adjust, but you never know. But in the event that happens and we need to do some redesign for the following year, it could be substantial, pending litigation and stays and all the things. But if there is a redesign, will there be ample opportunity for both the providers and the folks that originally sat at that table and had some input in design and conversation to come back together and have some collective conversation about the way forward?
You want to do that, or?
Yeah, I mean, I think you had, I think that'd be something, that'd be a hand that we'd all been dealt collectively. So collaboration.
Right.
If you need to restate that.
Yeah, so as Commissioner stated, we would look to collaborate with everyone if we see drastic cuts coming, and we would take a proactive approach to see all the input that we could, because that's going to most likely negatively impact a great many folks. Well, if there are no other questions, we really appreciate all we got one more? Great.
Not really a question.
Okay.
Brian Shirtfeed, Putney Health System. Been around long enough to know when this originally started with a physician DPP almost 7-8 years ago. Kind of coming out of COVID, I can't imagine what the industry would be in without these programs. I just wanted to thank the commissioner and DCH for your all's partnership, because I'll tell you right now, our 4 hospitals would be in a whole lot of hurt coming out of COVID without these programs that have provided new funding to be able to recruit physicians, recruit nurses, be able to look at quality programs differently, invest in our ERs. So just thank you all. I know there's a lot of technical jargon that goes into these things, and it's a lot of, we're all worried about these things, but it's so nice to have these additional funds in the state, and without it, I'm not sure where we'd be. I saw a local accounting firm did our audit recently, and by their reports, there's some 40% of hospitals that are losing money in Georgia right now. I can't imagine what that number would be if it wasn't for these programs. So thank you all for working on this and partnering with us to make them better.
Thank you for that. Anyone else? Well, I think that's a great way. Alan, you have a?
Yeah. Joe, I think we've had several conversations about this. And so I think what we find in the Savannah market, we're one of the fastest growing areas in the state. But from a jobs perspective, but from our Medicaid, what we're seeing is 55% of our Medicaid beneficiaries are coming off the rolls, and that's using the data that the DCH graciously provided to us as we check the eligibility each month for those that go through. But so what we're finding is obviously our hospital directed payment program, we flipped to a net contributor this year, and our DSH funds are decreasing as well from last year. 22 to 23. And so I'm not really sure what will happen with 24 until we see the numbers, if you will. But we're coming to a point where, at least for our health system, we're going to potentially flip into a net contributor. And so out of everything today, what's sort of the pathway forward? And I know it's a year by year, but you've got hospitals like us who are maybe flipping to net contributor or are just right on the line. And there's a number of us, I think, that are sort of in that boat. What do you see as the pathway forward?
Thank you for that. Sir, I don't have a great answer for that, but I will tell you what actions we're taking to look at all aspects of that. We're not standing still in that regard. But the managed care rule is such a big player in that respect. If the managed care rule stays, let's just say that they do cap it at 25%, then we've got to look and see, is there much movement that we have, right, to accomplish while maintaining stability. Outside of that, we're going to look and see if there are advantages to moving between different programs. Like we can look and see if there's advantages. I mean, AU came out when they went to Wellstar, went from public to private, as was referenced earlier. Is there an advantage to others being in an aid program and being at risk? We've got to model that and look at that. We don't want to do that this year because of all the things that are out there. But if we're looking at a year or 2 years beyond that, I think there are possibilities, depending upon what the managed care rule does, that may be advantageous. There is some speculation that the feds are going to exempt the portions of DPP that are at risk. So aid is at risk for, I think it's 10%. Kevin, did I get 10%? So if that were to be the case, then that would certainly change our thought process on should we have more folks in aid. And I think there are those out there who are willing to go into aid who would be at risk. And then what does that shift do to our overall revenue stream, and how does that look? So I do think that it's really all going to depend upon how we move forward, what CMS does with their managed care rule, and then that allows us to do different modeling. We're currently looking at those different models and how we might go about that. We've had a number of inquiries about adding to aid. So I think that's our most advantageous portion of that. We're also going to look at payment methodologies, as I referenced earlier. I mean, it came about when we talked about increasing HDPP, but that negatively impacted DSH. So we're just going to model as best we can and see if there's anything better than what we have and wait for the rule. Most likely we're going to be in status quo for this upcoming year, though. I do think, and I don't know for sure, and I know I owe you those numbers. We're working 2024 DSH numbers. I do believe that's going to be a positive. I don't know to what extent, but I am hopeful that that'll be the case for your individual hospital, but for those overall. Okay.
Word for word, does the current district penalize teaching hospital strong eligibility criteria? Does the next cost report here?
I don't know. That's a complex question there. I don't want to think that we're penalizing anyone by our current status. I'll go back to the fact that, when we initially started with the preprints and those who were eligible from the very beginning, there is the quality aspect that we were going to grow workforce and create a stable environment for those who qualified initially. And by most aspects, you would anticipate that you would have, up to 3 years in which to grow and have a stable income stream. So while new entrants, I certainly see that they see an opportunity to grow themselves at an individual level as they would meet the threshold if we were to advance the cost report. We also have to keep in mind that we've got to be beneficial to those who we're trying to grow and not negatively impact that growth in any way, and be able to meet our overall goal to CMS, which if we don't do, then we don't have an approval for DPPs as a whole. So I certainly understand the environment that they're looking at. It's again, going back to what we were just talking about, going to depend upon what the cap is, what our overall revenue structure is, and how many we could accommodate. Our current status is that we're going to maintain the status quo and where we are now and not advance that cost report, because we're right at the, close to that 25%. and there's just not room to accomplish that. Well, I think that we've stretched it out, and hopefully we've answered a lot of questions and brought some transparency, more transparency to this process today. Happy to do follow-up questions via email or phone call or however we may see fit. Certainly hope the association will help us guide any individual questions that may come your way. Really appreciate your participation today. And with that, we'll close it out. Commissioner, any?
Being participants, that's not just attending, the participants. Collaboration as we is needed. So thank you. And again, please take Joe up on the offer to further technical assistance, conversation, collaboration. Thank you all.